Okay, so let's get started. So, hello, I'm Laura Redwine. You have a picture of me, but not me, because at the last minute I don't have camera access for some reason. But we are very, very happy to have you here. Welcome to the Osher Center for Integrative Health's Wolfson Foundation Speaker Series. I'm Laura Redwine, Director of Research for the University of Miami Miller School of Medicine, Osher Center for Integrative Health. And it's my my pleasure to introduce you to Dr. Suzanne Steinbaum. Dr. Steinbaum is a globally recognized leader in preventive cardiology dedicated to transforming women's heart health. As the CEO and founder of Heart Tech Health, she is empowering women worldwide to achieve optimal cardiovascular health. Dr. Steinbaum has spearheaded, the groundbreaking women's heart health and prevention programs at Mount Sinai Heart, at Northwell Lenox Hill, and Beth Israel in New York City. She's a passionate advocate for prevention and accessible heart care and has been a national spokesperson for the American Heart Association's Go Red for Women campaign for over 20 years. Dr. Steinbaum is the author of an acclaimed book, Dr. Steinbaum's Heart Book, Every Woman's Guide to Heart Healthy Life. Her work has earned her recognition as New York Times Super Doctor, Castle Connolly Top Doctor, and one of New York Magazine's Best Doctors. She has served on the medical advisory board and as spokesperson of multiple companies throughout industries from healthcare to lifestyle to exercise, such as Peloton, Bayer, and Kellogg's. Presently, she serves on the medical advisory board of Women's Health Alliance and Women's Health Access Matters, and the Society of Women's Health Research, and also Women's Health Horizons. She has been a frequent guest on network television programs, including The Today Show, Good Morning America, and The Doctors. We are thrilled to have Dr. Steinbaum provide a presentation for our Grand Rounds. As Emily noted, please put your questions in the chat box, and at the end of the presentation, Emily will read the questions to Dr. Steinbaum. I unfortunately have to run off to an NIH grant review a few minutes right before 1 p.m. So I want to make sure all your questions are read by Emily. And without further ado, here is Dr. Suzanne Steinbaum.
Thank you so much. It's wonderful being here. I really look forward to hearing your questions at the end, but what I want to talk to you about today is truly the need for us to redefine the standard of care for women's heart health. Women and heart disease in the United States is at a difficult inflection point. Hang on 1 second, sorry. Heart disease is the #1 cause of death for women, and it really can affect women at any age. The statistics are truly staggering. 1 in 3 women will die of heart disease or stroke. Women spend 25% or more of their lives in poor health versus a man. 80% of the time it's preventable, and 50% of women are living with some form of cardiovascular disease. Only 56% of women know that heart disease is her #1 killer. And when you think of the cause of death, 1 in 5 women die of heart disease, more than all cancers combined. This late recognition leads to unequal care and really contributes to, again, what are preventable deaths 80% of the time, especially for high-risk groups. The cardiovascular disease burden is not equal. The one clear message is that non-Hispanic Black women truly have the highest prevalence. And in fact, 59.5% of CVD prevalence are among Black women. The clinical implication of this is that we have to prioritize aggressive prevention, access treatment intensity, where the burden is truly the highest. Health equity starts with recognizing who has the greatest burden. And when we look at this entire story, women in total are being impacted. And then when we look at who out of those women are being most impacted, it's African American women. The entire story of heart disease is really part of the problem because risk analysis is not accurate. We know about the traditional risk factors: high blood pressure, high cholesterol, diabetes, smoking, obesity, sedentary lifestyles, family history. Those all go into our risks. But the other side of the story are what happens specifically for women, or more commonly in women, things like autoimmune diseases. If you think about the disease lupus, you have a threefold greater risk of heart disease. Yet we don't even ask about that or integrate that issue into our risk analysis. When there are adverse outcomes of pregnancy, any kind of complications, preeclampsia, gestational diabetes, there is a significant increased risk of heart disease later in life. Now, the cure to having preeclampsia is to give birth, and then the woman goes home without having any follow-up with a cardiologist. When you go into menopause, your risk of heart disease goes up greater than fourfold. And depression, there's a twofold increased risk. Lately, in the past week, PCOS that we have thought of as polycystic ovarian syndrome, oftentimes a cause of infertility, is now been renamed polyendocrine metabolic ovarian syndrome because we know it actually increases the risk of heart disease based on the issues of insulin resistance leading to diabetes and hypertension. So there is an awareness that our risks are being missed. And in fact, the standard risk analysis misses women's risk about 50% of the time. So what that means is right now, when you often go into a doctor's office and you get a risk analysis, you are told you're not at risk. It's normal. You're getting this false reassurance that things are okay, that you don't need testing. But then if you're at moderate risk and testing is done, oftentimes this testing misses disease in women's arteries as well. And why? Our entire paradigm is based on disease in men, from the risk analysis to the diagnostic testing. Those tests are optimized for obstructive disease, blockages that are greater than 70% in the arteries. And for women, disease is often diffuse. And I'm going to go through this a little bit more later. But when disease is throughout the artery, our testing doesn't even look for that. So missed risk leads to missed prevention, but it also leads to false reassurance that you're okay, when in fact you might not be okay. Women also have different symptoms. And what this means is we're basing it on the classic symptoms. Those classic symptoms are often what we hear about when men have heart attacks. That concept in medical school that we learn is an elephant sitting on the chest. But there are non-classical symptoms as well. There's chest pressure, there's shortness of breath, there's extreme fatigue, there's jaw pain, back pain, nausea, vomiting, even flu-like symptoms. These patterns are not classical, but it doesn't mean that it's non-cardiac. The awareness that these symptoms could be a heart disease for women is between 40 to 56% of women know that this is their problem. So after this talk, tell 4 friends, because the more people that understand this, the more women that really empower themselves with this information, the more chance that they'll get the help that they need if in fact they're having a problem. Awareness improves recognition, and it improves the way we communicate with our doctors, which becomes really, really important in closing these care gaps. Atypical symptoms, as these symptoms are called, does not mean non-cardiac. We have to expand our lens to look at women a little differently so we don't miss disease. This is one of the most startling statistics. When women go to the emergency room with these atypical symptoms, they are 7 times more likely to be sent home from the emergency room when they present to the ER with a heart attack. And in fact, many times a woman will present with all of these symptoms. 50% of the time, they are giving the wrong initial diagnosis at first, and they are either sent home or they're giving the diagnosis of something like gastroenteritis or stress or depression. And what that means is that they're either not going to be treated, they're getting a false reassurance that they're fine, and they don't actually get follow-up workup, or they're sent home where they have a heart attack or something bad happens. If you have a problem, being sent home is just the beginning of the story. It's not the end. So when we look at women's hearts, it's really built on the male physiology. It's built on the male risk factors. And we have to look at these 3 specific points in time in a woman's life to really understand her risk a little better. It starts in pregnancy, as I mentioned, preeclampsia, gestational diabetes. You have a greater lifetime risk. And why this is important is because now prevention, now diagnostic testing has to happen earlier. During perimenopause, what happens is there's an increase in LDL, the bad cholesterol, an increase in blood pressure, insulin resistance occurs. That's the foundation of type 2 diabetes. Belly fat develops. All of this increases risk of heart disease. And by the time we get into menopause, there's about a 4-fold increased risk 10 years after menopause develops. This estrogen decline that many of us have been hearing about is essential to address. And this is the importance of really looking at hormone replacement. Metabolic hormone treatment is not for everyone, but it could be an essential part of prevention of heart disease by decreasing that insulin resistance, by helping the arteries dilate. And when those arteries dilate, there's a decrease in blood pressure. By changing this increase LDL, bad cholesterol, and decrease HDL, good cholesterol, and changing that ratio, what it does for us is creates a window of protection to decrease cardiovascular risk. Again, it's not for everyone, but for women who are going through perimenopause, even before they get to menopause, having that conversation with their doctor is critically important. And early identification and aggressive management of these risk factors is critical to reducing cardiovascular mortality. When I look at how prevention should take place, this is how we redefine it. It's not just looking at the basic risk factors, it's looking at a woman holistically. Who are you? What is your life like? Are you a caretaker? Are you under stress? Are you that sandwich generation taking care of both your children, your parents? Do you have work stress? Social determinants of health. What is your financial situation like? Transportation, all of these things, because how we live every single day, what our lifestyles are like, plays a role in this. And where it plays a role is through stress, through inflammation. All of these issues actually have an impact on our arteries. We then need to look at your metabolism. Those are things like insulin resistance, belly fat, that lipid analysis, the cholesterol, all of that plays a role, as well as your genetics. Things like LP little a and ApoE. Is there a family history of sudden cardiac death, multiple heart attacks or strokes, even dementia? All of these things matter. We need to understand the anatomy. What is the structure of the heart? What's going on inside of the arteries? Is there calcification or is there soft plaque? Inflammation is critically important. And when I talked in the beginning about autoimmune disease, inflammatory diseases, things like lupus, but rheumatoid arthritis, Crohn's disease, ulcerative colitis, All of these diseases that are more prevalent in women are important to understand in your risk. And what we often look at is a high sensitivity C-reactive protein that gives us an understanding of inflammation, but that might not be enough. And talking to your doctor about this as well is important. Functional data, how well you can exercise, what's your VO2 max, the amount of oxygen delivered to the muscles per minute. It's an essential metric of vitality and cardiovascular health, as well as your hormonal status that we just talked about, and your autonomic nervous system, that sympathetic nervous system, that fight or flight response that goes on through your days that actually has a profound impact on your heart. Traditional tests can really miss these key risk signals. So some of the things that I just mentioned, Lp(a) is a genetic marker. It's not been considered a standard blood test that's done in the cholesterol panel. And in fact, it wasn't until recently that the American Heart Association said this is a novel risk factor that needs to be checked for women to, for all people, but certainly women to understand her cardiovascular risk. The Lp(a) is much stickier than the LDL. It is associated with clotting. It is associated with premature and early cardiovascular disease. So even when an LDL is somewhat normal, having an elevated Lp(a) makes that LDL much riskier, much stickier, and there is development of plaque much, much earlier in life. So getting an Lp(a) is essential. And LDL is just a window into cholesterol risk. So when a cholesterol is checked, we look at total cholesterol, HDL, which is often talked about as being the good cholesterol, triglycerides, that's associated more with carbohydrates and sugars. We want that triglycerides to be less than 150. That's often associated with an elevated hemoglobin A1C or elevated sugars in the blood. And then we look at LDL, that bad cholesterol. What we understand is that LDL is just a window. The apolipoprotein B is a much more exact assessment of risk of cardiovascular disease when it comes to the lipids. ApoB counts those particles that lead to plaque. There are other things besides LDLs. There's IDLs, there's VLDLs, there is that Lp(a), and the apolipoprotein B counts all of them that actually lead to risk of heart disease. And the hsCRP is an inflammatory marker. It signals inflammation inside the artery. This inflammatory risk is some of the beginning stages of how plaque develops. And it lets us know that a plaque in the artery might be there, might be what we call vulnerable, potentially leading to rupture and leading to heart disease. And looking at these biomarkers along with your risk analysis can help us determine who actually needs imaging, who needs a CAT scan, who needs a stress test, who needs an angiogram. This helps us decide our clinical guidelines and helps us determine how aggressive we need to diagnose and prevent. This is an angiogram. I want to show you this because I want you to see what this actually tells us. These are the big arteries, the epicardial arteries, the arteries on top of the heart that we look at in an angiogram. We can tell if there is obstructive disease in these arteries. We can see if there is a blockage. And when we see a blockage, we can put a stent in. We often do this when there is symptoms and an abnormal stress test, and it gives us an understanding if someone needs a stent. Here's a CAT scan angiogram that tells us the same information. It is not as sensitive and specific for those people that might need a stent in the arteries, but again, it is looking at those larger, big arteries. And we can see if there's a blockage in one area to put a stent in. Here's a stent. That's what it looks like inside of the artery. You can see here some low density plaque. This is what we look for to determine if there's non-calcified plaque in the artery that might be obstructive, blocking flow greater than 70% when a stent might be needed. But here's the difference between men and women, and this is one of the most important differentiations. Men get disease in that one area. We can look at that angiogram. We can look at that CAT scan angiogram, and we see that one location of blockage where we can have an impact. We can put a stent in. We understand that this is increasing the risk of lack of blood flow, what we call ischemia, to the muscle of the heart, and that person would benefit from a stent. That's oftentimes when the blockage is 70% or greater. In women, it doesn't look like that. There is disease throughout the artery. That's on the bottom part of this slide. That disease throughout the artery means that we might actually not be able to appreciate it in an angiogram. That when we look at that catheterization, when we look at that angiogram, the whole artery has diffuse disease, diffuse plaque, so it almost looks normal. When we do stress testing, this is a nuclear stress test, it looks absolutely normal because disease is diffuse. There is not one location. And when you look at a stress test, it picks up that one area of disease. It compares abnormal to normal. And so in men, it's really easy. In women, there's no exact normal to compare it to. It's diffusely abnormal, and a stress test, including a stress echo, might give us the false assurance that the arteries are normal when in fact they actually are not. Those normal functional tests do not always close the case, and it does not exclude coronary artery disease in women. The optimized ischemic disease does not come from the nuclear stress test, the stress echo, because of how this disease not only presents, but also because disease in women is soft plaque. It's not calcified plaque. It's also coming from the small arteries, the microvasculature. What we call that disease in men is obstructive disease, but that's one type of disease. Those risk factors that we talked about might lead to that diffuse disease, or it actually might lead to soft plaque that we might not be able to see or appreciate. Or again, it might occur in the microvasculature. What's so interesting is the paradigm of how we have looked at cardiology is that when someone has chest pain, they get a stress test. If that stress test is abnormal, they go for an angiogram. If that blockage is 70%, they get a stent put in, and we are told they're fine. Here's what the truth is. Most heart attacks happen when plaque is 30 to 50%. And in fact, these plaques rupture, leading to thrombosis or clotting in the area of that rupture. That clotting blocks blood flow to the muscle of the heart, and that is a heart attack. In women, when this disease is 30%, 40%, it can erode slowly over time. It's not always this massive heart attack. It could be a silent heart attack or something very, very subtle, this nausea, this uncomfortable feeling in the chest, which is why these symptoms are so different. And this non-obstructive disease, women are often told when they have a CAT scan angiogram, you're fine, but you're not exactly fine. This is when medication, lifestyle intervention like diet and exercise, stress management to decrease that sympathetic nervous system, to decrease the inflammation. This is when All of those things that we talk about in terms of prevention and treatment become so important. The development of plaque begins in the lining of the artery, and that lining of the artery is called the endothelium. I often describe it as the lining of a pocketbook. You know, you have a lining and then the leather outside of the pocketbook, and there's a little tear in the lining, and inside of the lining goes your keys, your wallet, gum. You can't find anything anymore because it all goes inside of that lining. But it doesn't begin in the arteries until that artery becomes stiff. And when that artery becomes stiff, and that could happen during preeclampsia, that could happen during perimenopause or menopause, the artery becomes stiff, your blood pressure goes up, and micro tears happen inside of that lining. In those micro tears, cholesterol goes. The body knows that the cholesterol should not be inside of there, and it sends cells, these fighter cells, to get them out. They turn into what we call macrophages or foam cells with some inflammation up there, and that grows. That is the beginning of plaque. This is when a calcium score might be 0, but in fact, plaque is there. And as plaque matures later on to later stages, calcium develops on top of it. When we treat someone aggressively, calcium increases because we stabilize a non-calcified plaque to become calcified. So when we have this idea of calcium scores increasing, we think of it as being a bad thing. It might not be a bad thing because that non-calcified plaque, that immature plaque that tells us that disease is starting or beginning or is developing, we want to change that to become calcified. We want to mature it. We want to stabilize and stop the progression of disease, and only make sure that we stop that by looking at non-calcified plaque. And I'm going to explain how we do that as we go along. We also need to look at the most common cause of symptoms in women, and actually the most common cause of vascular disease in women, which is microvascular disease. In symptomatic women, microvascular dysfunction is the most common and is associated with that non-calcified plaque. In fact, 66% of women with symptoms have microvascular disease. They produce symptoms that are similar to ischemic or disease with with an obstructive pattern. They might have chest pain, they might have shortness of breath, but by all standard testing, everything is normal. The reality is this increases the risk later on. And as time goes on, silent heart attacks or rupture of plaque can happen. And it's very important for us to look for soft plaque in women that have microvascular disease. This is the difference between being told you're fine and getting a diagnosis. There's one statistics that women who have cardiovascular symptoms, chest pain, shortness of breath, 59% of those women go through what we call medical gaslighting, which I know is a new hip word to use. But the reason for that is because we have not had the accurate tools to risk stratify and to diagnose heart disease in women. Heart disease in women is simply a different disease than men. And that's why we need to change the paradigm. We are looking at those tiny, tiny arteries in this picture on the left. That CAT scan that I showed you, the angiogram, the catheterization is looking for those big arteries, not those tiny ones in the picture on the left. And that is what we need to look at when we can't figure out anything else. And we need to look at that soft plaque as well. That microvascular disease diagnostic pathways right now include a cardiac MRA, looking at a stress perfusion imaging, looking at blood flow, an invasive angiogram, injecting what we call acetylcholine and looking at the function of the arteries, a PET scan, or a cardiopulmonary exercise test, which is what I actually use in my office. It assesses not only VO2 max, the amount of oxygen delivered to the muscles, exercise capacity, but it tells us how well the arteries are dilating. And we look at the anaerobic threshold, which is at the point when during exercise, the body goes from aerobic oxygen delivery to anaerobic exercise, which is when we start using our internal sugar stores and burn those. When that happens early in exercise, we know that that is a sign that there is a lack of arterial dilatation. The stress test looks like this. You wear a mask, you're hooked up to an EKG, and we push you on a bike until we get this data. Microvascular disease is often those early stages of disease, but we don't appreciate it until it starts affecting those larger, bigger arteries. That's when we can do stress testing. But early on in disease, that's when women get lost. And I believe that's why the statistics are still so bad when it comes to women in heart disease. When we look at the cardiopulmonary exercise test, the American Heart Association has actually said that cardiorespiratory fitness should be considered a vital sign, the same as blood pressure, the same as heart rate. And it should be one of the most important additional tools that we use in assessing women's risk. The other issue is that the calcium score has become a tool that we're using on top of lab testing to determine whether a woman is at risk. As I explained to you before, non-calcified plaque happens more often in women. It's the earlier stages of disease, and calcium scoring doesn't happen till about 10 years later than men. So a calcium score of 0 is not the same as a risk equaling 0. That a calcium score tells us something. It tells us that if it's elevated greater than 1, that we know probably non-calcified plaque is also there. But that calcium score of 10 or 20 or 30 doesn't tell us how much disease is there, how much non-calcified plaque is there, and if in fact, if there's also microvascular disease. There is a way for us to tell us all of this. The cardiopulmonary exercise test can look at the microvasculature. It can tell us how well we're exercising. It could tell us if there's stiffness in the arteries. And if there is, we actually can do things, including an exercise prescription to prevent it from getting worse. We can look for non-calcified plaque in a scan called a Clearly scan, which is an AI scan. It's using a CAT scan angiogram, that CAT scan I showed you earlier, looking at the arteries, but it actually looks for soft plaque that is much more difficult to detect and is much more advanced than just a calcium score. It quantifies that non-calcified plaque. And using this AI precision, it standardizes quantification of that non-calcified plaque to tell us risk. Besides the blockage, besides telling us how, if the blockage is 30%, 50%, 70%, which is the standard of how we look at CAT scans, it gives us an understanding of risk by telling us how much non-obstructive, how much soft plaque there are, and that risk stratification is actually more sensitive for women. It gives us this moment of imaging for women that we have been missing for decades. This one study I found so interesting because it actually looked at women specifically. 50% of the cohort were women, and that data was assessed specifically on women, not on women and men together, which makes a really important difference in how we analyze the data. This sex-specific risk stratification showed us that although there was a higher amount of plaque in men, the similar high-risk plaque features that men and women had, looking at the soft plaque, gave us an understanding of greater risk for women. There was a greater amount of heart attacks, strokes, hospitalization, and death for women that had the greater amount of non-calcified plaque compared to men. It wasn't about the blockage. It was more about how much of that plaque there was. And now we have a greater understanding of how to predict risk in women. I wanted to go through some cases just to really explain the power of this. I met JC, a woman who it was 2021, and she presented with high cholesterol, high blood pressure, and a strong family history. Before we met, she had calcium scores done. In 2008, it was fine, nothing was done. In 2013, it was 63, and she was told she was okay, she was fine. In 2020, she had another one. And in those 7 years, her calcium score went from 63 to 246. The interpretation of that is not just that her calcium score went up. The interpretation of that is that she's had progression of disease, that there is non-calcified plaque that is developing, and that non-calcified plaque over time actually became calcified. It is telling me that disease is there that has not been treated. She's had a strong family history of heart disease as well. And when a clearly was done, in fact, she had a total score of 214, but she had a non-calcified score plaque of 85. 2 years later, we repeated, her score went up to 234. Her non-calcified plaque was 91, but her calcified went from 128 to 143. Now, just that there was an increase in calcium doesn't mean badness, because that change of calcification from 2022 to 2024 of 83 to 91, and here is the comparison, showed us that there was actually, the comparison there was that there was a decrease in non-calcified plaque and an increase in calcified plaque. What this showed us is that we stopped disease progression. And the way we did that was through medication using rosuvastatin, Repatha, Wegovy, and losartan. So we controlled her cholesterol. We controlled her LP little a with Repatha. We controlled her metabolic issues with Wegovy and her blood pressure with losartan. We put her on an exercise prescription of moderate intensity cardiovascular exercise, 30 minutes, 5 days a week. We put her on strength training. We discussed her diet and suggested a Mediterranean diet, high in omega-3 fatty acids, low in animal fats, low in saturated fats. We actually decreased her inflammation and got her LDL and ApoB down to 41. We can't impact those genetic markers like LP little a, but we changed the outcome of her disease. And by using a clearly, we showed an increase in that calcification and a decrease in that non-calcified plaque. She's followed by a cardiopulmonary exercise test, and we've actually showed improvement of arterial health by her exercise prescription and by her medical management. The next patient, NL, is a 63-year-old female. She has high cholesterol and a father that had a heart attack at 58 years old. She also presented with high cholesterol. And she didn't want to have anything done. She had a normal stress echo and she decided she was fine, but a cardiopulmonary exercise test was done that showed microvascular disease. She started doing Pilates 4 days a week and exercising. I suggested a Clearly. And in September of 2025, she had a total score of 248, non-calcified 108, calcified of 139. And she had a percentage of atheroma volume, the amount of plaque in the arteries, 9.1. What's important to understand is when that atheroma volume is greater than 7%, the outcomes are significantly worse for heart attack and stroke, threefold. She has blockages in the arteries, the LAD, the main artery, 36%, and the circumflex around the left side, 42%. And she is somebody that I said, medical management is essential. We have to start rosuvastatin, an exercise prescription. We started Crestor at 10 milligrams daily. We did a cardiopulmonary exercise test, started her on 30 minutes, 5 days a week, really talked about her diet and the importance of stopping saturated fats. Again, omega-3 fatty acids, vegetables, legumes, beans, nuts. And we have yet to repeat her test, but she is actually feeling a lot better. So when we go through the risk assessment, it is incorporating not only just the basics, the blood pressure, the cholesterol, the sugars. We look for really the metabolic issues. We look for inflammatory. Where is that coming from? Is it coming from stress? Is it coming from depression? Is it coming from not sleeping? We look at the functional data. Can you exercise? Because exercise and cardiovascular vitality is one of the most important signs of longevity. We look at genetics, we look at the hormones, we look at the psychosocial, that depression, anxiety. Again, all that goes into lack of sleep, not being able to take care of yourself. And then the preventive strategies. Yes, we give medication if needed, but we talk about exercise as being essential, probably the best medication I can give, but unfortunately, the patient has to do it. We talk about the importance of diet, even supplements. We look at omega-3 levels. We look at vitamin D levels. We really use supplements to support. We don't give it to everyone. We give it if needed. If the arteries are stiff, we will give something to dilate the arteries, like a high concentration of resveratrol or L-arginine to help support arterial dilatation. We talk about stress management through yoga, through meditation, through even group support, mindfulness, breathing techniques, something. And we talk about sleep. One of the most interesting things now is we have remote patient monitoring in the form of a watch, whatever watch you choose, to tell us about how well we're doing, how well we're exercising, how well we're sleeping. Heart rate variability is an indication of the nervous system, of the autonomic nervous system. When the heart rate variability goes up, we know that fight or flight response has gone down. We know we're exercising better, we're sleeping better. We can actually keep track of ourselves on a daily basis to understand if our intervention is decreasing the potential of plaque from developing, from keeping our arteries healthy, from making sure our microvasculature that is not always diagnosed and appreciated is being reversed, because 80% of the time, heart disease is preventable. I wrote this in my book that was published in 2014. What we're talking about today, longevity, has actually really been preventive cardiovascular care. And for women, it's a little bit different. This is truly my viewpoint. It's about living from the heart, taking care of the heart as if it is the essence of who we are. We should live truthfully, authentically, and honestly, drawing strength and consolation from work, from family, love, and health, and cultivate and nurture those things, not from your head where logic always rules, but from your heart, where you can feel what is right and real for you. Live that way, and chances are things are going to be just fine. Thank you.
Thank you for this wonderful presentation. Very, very informative. So uh, next, I guess we're going to be asking if participants in this presentation have questions. Are there any in the chat box?
Yes, we have one. One of the participants asked, if you have osteopenia and an elevated LPA, my doctor has told me not to take calcium. Besides for diet, is there anything that would be helpful?
So this gets back to understanding risk and really understanding if you are at risk. And it's not LP little a alone that helps determine that. It's also understanding the other things I talked about. What's your ApoB? What's your hemoglobin A1C? What's your inflammation? Have you had a stress test? Do you have any symptoms? Are you exercising? Have you had a calcium score? Now, if you have an elevated ApoB, an elevated HSCRP, along with an LP little a that's elevated, then I suggest doing some advanced testing, see your risk, and understanding that. Because the reality is, treating the cardiovascular side of this is the most important thing. When you do that, then taking calcium for osteoporosis is fine. What we've known through studies is that many times when you take too much calcium, there's an increase in calcium in the arteries. So it's more about the amount of calcium you take, and it's also more about having your risk treated when in fact you are at risk, and not to overdo it. But I don't say to my patients, don't take calcium because your LP little a is high. I say, let's prevent heart disease and let's prevent osteoporosis, and let's do it in a holistic way that keeps you safe.
Thank you. We had another participant that asked, what supplements do you recommend for women in perimenopause and or menopause?
Supplements are so interesting. I'm sure everyone has seen all the supplements you're supposed to be taking. I'm not a big believer of that. I think you take what you need. And that oftentimes can be checked in the blood. You can check a vitamin D in the blood. You can check an omega-3 in the blood. You can check for B12 and magnesium. And so I advise you to get those things checked. We oftentimes can get enough omega-3s from our diet. It's interesting because omega-3 is variably absorbed. Sometimes you're eating a lot of nuts and your omega-3 is still low. You might add fish and your omega-3 is still low. Some people hate fish and can't force them to feed them that. And that's when supplements, I think, are really important. Um, I have a patient I actually was talking to yesterday. She's like talking about vitamin D. Should I go out in the sun this summer to increase my vitamin D? And I'm like, well, aren't you wearing sunblock? And she's like, yes, and a big hat, and I'm under an umbrella. I'm like, yeah, then you got to take a supplement. It's sort of the reality of where we are. I find that some supplements that dilate the arteries are really healthy. And I actually started working with this company because I love the research behind it. They're called Vinia, Vina. They're a high concentrated resveratrol. Resveratrol we've known about for years because it's on the lining of grapes. That is the French paradox. I don't know if you heard it, but that's the French people don't have as much heart disease. And everyone said it's because they're drinking red wine. I think it's because they don't eat as much and they walk, but whatever. I think that resveratrol is super powerful antioxidant. And the way that this one company, Vinia, actually created their resveratrol is it's concentrated so much that it increases nitric oxide, and nitric oxide helps dilate their arteries, and it decreases endothelin 1, which causes constriction of the arteries. I don't know if it's for everyone. I wouldn't tell you you're going through menopause, perimenopause, go on it. What I will tell you is the most potent and powerful thing you can do is exercise. And I hate to say that because everyone wants to take a pill, but you've got to believe me that 30 minutes, 5 days a week of exercise is more powerful than any supplement that we can take. 3 days of weight training is going to exceed anything that I can give you. And then there are supplements around this that we hear about that are interesting, not for everybody. There's creatine that I have that's piqued my interest because there's been a lot of research done around that in the 90s. I don't want people to just hear somebody and say, I'm going to take that, because that is not exactly the way that research is done. Question things, really look at the data, really understand if it's right for you, because not all of the things are right for you. If you take creatine and you're sitting on the couch, it's not helping you. I'm just letting you know. If you take creatine and you're doing some weightlifting, it's going to have an impact. And so that's the difference. Just become educated. The more you educate yourself, the more you can really advocate for yourself and become empowered. And I think that's where we are in medicine right now for women. As women, if we don't know the story and we don't empower ourselves with the really good information, we're getting missed. We're getting lost in the system for all the reasons that I explained to you. And so just before you take a supplement, just learn about it.
Thank you, doctor. Another participant asked, what about when everything is good according to blood work, but you have high LP little a? Could it be genetic?
So it depends a lot on the other risk factors. Everything goes back to these risk factors, which is why I started there. Because if you look at the traditional risk factors, if you're less than 65 years old as a woman, you're considered low risk, even if you have a high LP little a. So I need you to go back in time. If you were pregnant and had children at any point, what happened during pregnancy? Did you have any complications, any risk? Start there. Do you have any autoimmune things? Rheumatoid arthritis, celiac disease. I should have brought that up because a lot of women have this like spectrum of celiac. If you actually have an autoimmune celiac issue, that becomes a risk factor. Are there any other inflammatory issues going on? Really understand that ApoB. Everything being normal doesn't mean you're okay. And that's when advanced testing. So if you're a woman who's postmenopausal with an elevated LP little a, I would suggest getting a clearly CAT scan. Maybe talk to your doctor, go through these risk factors, because it'll see if there's non-calcified plaque there. And how much non-calcified plaque is there, depending on your age, will actually tell you your risk. And if you have that disease, and this is the most powerful piece of this entire conversation, I want to tell you, if you treat that disease before you're sick, before it develops into something, it will change the rest of your life, because you will never, ever get heart disease. The earlier you treat it, the earlier you can prevent it. And 80% of the time, we can actually change the outcome of your life if you get diagnosed early enough and treated early enough.
Thank you. Another question, we have quite a few, so pardon me. We may go over a 1 p.m. mark if that's okay with you. I'm going to be respectful of your time. How often should women get CT calcium screening test?
So I'm not a huge fan, as I was saying. It kind of gives the false sense of security. If you have a calcium score of 0 and you repeat it 3 to 5 years later and it's still 0, I'm not sure, depending on your age, what that tells us. Now, the duration of time between them. So if you were 50 when you had the first and 55 when you had the second, and it's still 0, that's a really good sign. But if you've had a strong family history, and that family history is in a sibling, that actually increases your risk, believe it or not, more than a parent. I would tell you, you have to make sure you know your LP little a. You need to make sure you know your ApoE. And ApoE 3, 4, or 4, 4 increases your risk not only of heart disease, but of Alzheimer's. But it is an important part of this story. And I would say that anyone who's have a strong family history, who has an LP little a, who is on medication, who is postmenopausal, those risk factors are reason enough to say, I need a CAT scan angiogram. I need a clearly CAT scan. I need further testing. I need early diagnosis for aggressive prevention so I make sure this disease doesn't get worse.
Thank you. How do we best advocate for a CCTA test? I have lost a brother at 61 to a widowmaker heart attack, and my other brother had a stent put in 2 years ago. My cardiologist says I am quote unquote fine.
That just gives me chest pain. Sorry.
That's okay. Feeling scared and would love to have a more reliable test than a stress test. Thank you.
I want to answer this in 2 ways. I'm going to answer this as a cardiologist with a specialty in women and heart disease that spent 25 years in this field as everyone's second opinion. Because most of the women who come see me have been told they're fine. And there is nothing that upsets me more, because this is why more women are being misdiagnosed, undertreated, and is why I do the work that I do. And so the conversation with your doctor is, I just heard this lecture from a cardiologist who spent 30 years of her life focused on women and heart disease. And I think you guys are going to share this lecture. You can give him the link, tell him to listen. If he's not interested, and this might be a very harsh thing to say coming from a doctor, you got to find somebody that you can work with. You might need to find a second opinion.
Thank you. Another participant asked, what are the other levels that should be considered besides LP little a? I think you said ApoB. What is needs to be considered?
So apolipoprotein B, LP little a, hemoglobin A1C. Let's make sure you don't have insulin resistance as well. HSCRP is an inflammatory marker. That's also critically important. And I think with a cholesterol panel and those, you're getting a really wider view of your risk. I also check ApoE in my patients. It's a genetic marker. 3, 4, and 4, 4 is associated with coronary artery disease, but also Alzheimer's. Not everyone wants to know that information. It doesn't mean you're going to get Alzheimer's. It means that you're at risk for, and changing your lifestyle, like diet and exercise, low-fat diet is critical. But I think what is super important is that you get all these things checked first, and you go through that risk analysis again to make sure you don't have any of those other things like preeclampsia. We can't check for that anymore. There's no blood test for that, but that is something that is part of your risk analysis.
Great. So we have a few comments. One participant said, I am 45 and my iron level has not gone up to 11 always, around 10 to 10.8 for years. I take iron pills prescribed and I do iron infusions from time to time, but it is so frustrating.
My gosh, that is awful. So I think that you have to make sure, and I don't know enough to understand about menstruation, and usually iron deficiency is because of too much bleeding. And so I like to look for what we call the root cause of everything. I like to understand why things are not happening. For example, I am fairly certain because of this, you're tired, you're probably very fatigued, and because of you're very fatigued and tired, you probably have a really hard time exercising. And when you don't exercise as you grow older, it's not good for your arteries. So the reason that you might not be exercising is because you're iron deficient. So that's an example of a root cause. So when we look at iron deficiency, we got to go back a little bit. Why? The reason, I don't know, but you need to understand the root cause. You need to find the reason. And then when the reason is found, address that. Because it sounds like short of having regular iron infusions, like weekly, your iron is just not going to go up. You need to know why. You've got to figure out the why behind that.
Thank you. Another comment by a participant: I can't take the medicine for the osteopenia. The side effect causes stomach cramps, resulted in having 3 small bowel obstructions.
Oh my gosh. Hearing these stories, I'm so sorry you all are going through all this. It's not easy. It's not easy managing our health, and how we feel physically from these things. I mean, a small bowel obstruction is not a small thing, and I understand why you're asking the question. It comes down to really the non-medical things. It comes down to the calcium and vitamin D. It also comes down to the weight-bearing exercises, the creatine, the jumping, the things that we can do for ourselves that actually increase our bone density. And talk to your doctor. Make sure there's not anything else. There's actually medication that is very, very different out there. It's under the umbrella of food is medicine. It has what's called genistein in it. And this product has been shown to actually increase bone density in women that can't tolerate those other medications. It's called Fostium. Fosteum. And I would look into it, share it with your doctor. It's fairly new. I just became familiar with it myself. I find the research behind it very compelling. And so maybe you can talk to your doctor about using that, as well as the things you can do on your own. Every time I give someone a medication, whether it's for cholesterol, whether it's for blood pressure, whether it's for sugar, I'm like, now what are we going to do? What are you going to do? How are you going to exercise differently? How are you going to eat differently? How are you going to sleep differently? And I think that piece you've got to lock down and then try the Fostium.
Thank you, doctor. We are almost done. How are you on time?
I have a appointment. Hang on one second. Let me just let them know I'm running late.
I want to be respectful. We're almost done, only 4.
I can just do a couple more.
Okay, so I have a participant asking, and I can share this with the entire group. If you and I can connect and have a little bit more information of the Vina supplement or
Vinia. It's VINIA, VINIA.com, and you can look at their website. They're a great supplement.
Perfect. And then another comment, since LP little a and Apple B are not really part of regular tests, clearly is a new scan. Do you find challenging approval from the insurance companies?
So not for ApoB and LP little a. I have not seen any insurance company balk on that, especially because the American Heart Association is recommending that. Um, Clearly, it depends on your insurance. It depends on where you live, and it's not done everywhere. So that one is a little more challenging, and it's varies depending on location. Actually, they have a really good website, and I know that they have a section for patients to look up stuff. So you can look on their website as well.
Yeah. Okay. One of the 2 more comments. Another participant, I have osteoporosis and my doctor says not to take calcium supplement. I used to take plant calcium. What do you recommend? I take rosuvastatin and amlodipine. I might.
Yeah. So hang on one second. I am now getting actually summoned. I am so sorry. I I just got distracted because of this. Tell me again the question, and I can only take this question and then I have to run, okay?
This participant said, I have osteoporosis and my doctor says not to take calcium supplement. I used to take plant calcium. What do you recommend? I take rosuvastatin and amlodipine.
And amlodipine. Okay. So again, this fostium that I mentioned is a really interesting plant is medicine kind of medication that you can look into. I think with the calcium, there's a recent trial that came out, and that's why everyone is kind of freaked out about telling patients to take calcium. It's really about not taking too much calcium, and there have been a lot of different trials about this. 1200 twice a day is max. No more than that. Over that is really dangerous. And so talking to your doctor about taking some, not all. Calcium also has to be taken with vitamin D. That's really important. And again, check out the Fostium. I actually am going to reach out to Vinia. I've been able to get discounts for people, especially because I talk about it so much. I will, Emily, I'm going to send you a discount code that you can share with everyone that they can use for Vinia if they want it.
Perfect. I will do. And in respect of your time, guys, I do see your other comments in the chat. I will send.
Sorry. Send them to me and I can answer them. Okay. All right.
Email. Thank you everyone for joining us. Dr. Steinbaum, thank you so much. And I look forward to working with you in the future.
Look forward to it. Thanks everyone for coming. Bye.